It's April 2020, and COVID is in full swing. This patient is still 62 years old, has a history of well-controlled hypertension, and the history of knee replacement surgery. They arrive in the hospital needing our care. Shortly after arrival, again, the patient begins to deteriorate, and the nurse calls a rapid response in order to transfer the patient. What is different now is the data on this disease is becoming clearer. The survival, once patients develop cardiac complications, is extremely low. In this transition, patients and families may be told what will happen, not engaged in a shared decision-making model. Most plans for crisis standards of care include guidance that if triage becomes necessary, bedside providers will relinquish decision-making to a triage officer or committee. This may help alleviate some of the moral distress that one will feel if we have to deny someone a resource that under different circumstances they would receive. We expect anyone in healthcare during this pandemic to experience moral distress. Very few people will have had time to reflect on and appreciate the need for the shift in traditional standards of care, and what we are doing will feel wrong. There are many definitions of moral distress, including the one from the Code of Ethics for Nurses. Moral distress threatens our core values and our moral integrity. There are essential components of moral distress, regardless of the exact definition. Individuals have a feeling that they are participating in wrongdoing. The wrongdoing is associated with professional values. People will feel they have a lack of voice, feeling that they are acting on decisions made by others without having input, and the wrongdoing has a serious impact for the patient in our care. Being a moral agent is someone who holds themselves accountable to their actions, even in the face of internal and external constraints. Empowerment to do the right thing comes from codes of ethics, even and sometimes especially when external factors push us to do something inconsistent with what we believe it means to practice with integrity. When everything is changing rapidly, it is hard to know what it means to be a moral agent, particularly if I have not been able to prepare for a shifting standard of care. So what is the role of ethics? As we walk through a map of moral distress, we encourage you to challenge yourself to move beyond your immediate emotional response and apply the ethical content we've provided in this presentation. Open your mind up and hear the perspective of others. You may not agree with them. Moral people can often disagree. This involves having some self-awareness and recognizing that decision-making goes beyond the mere application of standardized ethical meanings, decision-making models, and bioethical principles. Real life can be very complicated. These are the elements of what you would examine in order to map your moral distress. Examining your emotion is a way to honor the experience of the clinician. It is, in fact, the first step in deep self-reflection. It helps to uncover a threat to integrity. We'll examine the sources, in this case, the COVID pandemic. We'll look at some conflicting obligations. Naming them is a very important step toward reconciling how you must weigh them against each other. We'll look at forces internal and external. How do we support each other? Actions to alleviate the distress, and note that this is about the bedside nurse. And then actions to how we address patient need, because moral distress at its core is about how we help patients. Some of the emotions that we are confident people are experiencing would be fear, anxiety, powerlessness, anger, maybe even guilt. The source of the distress, summed up very simply, is too many patients, not enough resources, rapidly evolving events. Things are changing the way we normally do things. We don't have enough supplies. We're working with unfamiliar people. We don't have the ability to engage in the relational work of nursing. It is really important to the work of nursing that people learn their patients. Not only can we not speak to many of our patients, we can't speak or talk to their family members. Things that are internal to us. I have a commitment to individual patients. How am I supposed to let go of that? Nobody's prepared me for training in the sliding scale of standards of care. I don't have confidence in my skills. I'm working in a different unit. How am I supposed to speak up if I'm not sure? External things. I have institutional policies. Things are changing. Somebody's posted a new procedure for how I sterilize something. The strategies are unfamiliar, something I would never consider doing. Maybe I'm having a lack of information. I'm not getting enough communication from local, regional, and other leaders. And sometimes people disagree about what's the right thing to do. So when we look at what are the conflicting obligations and responsibilities, these highlight a few. I have the individual patient, and now I'm supposed to balance that against protecting the community. How am I supposed to balance my personal safety when I'm supposed to have this strong relationship with a patient? I have family obligations. My children aren't in school because they've closed them. Who will take care of them? What are my obligations? So there's this heightened sense of moral responsibility, and it's directly related to how the patient in front of us, what is their individual well-being? Individual patients may not get what we think they deserve, and we know that we will always do our best to get them what they need. You'll be better prepared to navigate these unfamiliar waters of shifting standards of care if you take care of yourself and you accept that doing your best is good enough. You must believe that prioritizing self-care will be your best strategy for meeting patient needs. Although nurses are being asked to do a lot of things, we must take pride in doing the best that we can based on the limits that are put upon us. Taking control of the things that we can do and accepting we may not get to everything on our list has to be good enough. We should do our best and be forgiving when it doesn't feel like it's good enough. And we can also help by reminding each other to take care of ourselves. Please remember to eat right, take a break, get some sleep, seek and accept emotional support. So what can you look for from your leaders? Seek out and get input from them. Ask for clear communication. Ask what ethical framework was used to create the plans. Sharing of ethical frameworks for making difficult choices has been developed. Plans call for implementation if and only if we have an absolute mismatch between the number of patients who need treatment and the available resources to provide them. Leaders should be able to help you understand the plans that are available for your institution. Just because you haven't seen the plan doesn't mean that it doesn't exist. Leaders should expect staff to have moral distress. They should reach out and not wait for staff to come forward. If your leaders aren't reaching out, please don't be shy. Please come forward, take care of yourself, and talk with your colleagues about the ethical challenges you're all facing. Addressing patient needs, we must always provide comfort to our patients and whenever possible, provide presence. We know that a significant source of moral distress in this pandemic has been the isolation that patients and families feel, particularly when patients die and families are restricted from visiting for safety reasons. It's hard to sacrifice good end-of-life care to meet the immediate goal of safety, knowing that it will come at a price, and that is an increased risk for long-term altered grieving and potential post-traumatic stress. Advanced care, well, at this point, it's now really just-in-time care planning is essential for everyone. Encourage patients and families to talk about what matters most to them. A difficult yet simple question to ask is, what would you want if things don't go the way you hope? Learning how to talk with patients using basic fundamental skills is really important in this time. Use empathic communication skills, such as the mnemonic NURSE. Also learn how to align with patients' values. That would be WUSH, hope, and worry. So how do we do our ethics analysis of what we've talked about today? The declaration of a public health emergency has shifted the standard of care. We know that a top priority has to be to prevent the further spread of the illness. And we can do that if we focus on protecting healthcare providers. As is true in any ethically challenging situation, this will not feel good, but that does not mean that individual providers are doing anything wrong. The stakes are very high in a pandemic. These are uncertain times, and we must accept that we may be faced with making tragic decisions under difficult circumstances. A fair process doesn't mean it feels fair. It feels wrong to limit visitors to a patient. It feels wrong to not have enough PPE or to have to reuse it. It feels wrong to not have enough ICU equipment and staff for all who need it. It feels wrong to be placed in a nursing unit or in a circumstance that's unfamiliar to you. Like our patients, we will not have access to the choices we normally have. Our duty to care means that we can bear witness with and provide comfort for all our patients, regardless of the level of treatment we have to provide them.